Welcome to the Tim Booker Book Sharing channel. Here, we delve into the endless world of words, savor captivating stories, and share insights and reflections. Remember to like the video, subscribe to the channel, and hit the notification bell to stay updated. Let's embark on this reading journey, experience the allure of words, and explore the ocean of knowledge together.
Today I'll be interpreting The Price We Pay for You. Living in the modern age demands a steep price for maintaining good health. It's almost common knowledge that anything can be ailing, and everything can be expensive. The American healthcare system stands as one of the most advanced yet also the priciest worldwide. Logically, it seems justified. But does buying health truly adhere to the principle of, you get what you pay for? Consider these facts. Suppose you need a coronary bypass surgery in the U.S. Researching different hospital prices, among 53 disclosing their rates, the lowest quote for the procedure stands at $44,000, while the highest hits a staggering $448,000, a $400,000 chasm. Oddly enough, there's no evidence to explain any discrepancy in treatment efficacy that justifies this vast difference. You don't opt for the priciest or cheapest option but settle for a hospital quoting $150,000. Utilizing your bargaining skills, you manage to whittle the cost down to $25,000. Yet, to your surprise, you find that a hospital in France with a comparable standard offers the same surgery for just $15,000. Apparently, these hospitals wield the power to set their own prices. So, how did this healthcare price dominance emerge in the U.S.? And how does it presently impact the lives of Americans? The Price We Pay offers insightful answers. The author, Makary MD, holds a professorship in gastrointestinal surgery at the prestigious Johns Hopkins School of Medicine. He isn't an advocate for healthcare legislation, a journalist, or a critic. He's an insider, a cog in this costly healthcare machinery. For an insider to write a book exposing issues within the American healthcare industry requires immense courage. Moreover, this book isn't just a rant about the exorbitance of American healthcare, it's about actionable solutions. The author founded an organization that, through constructive initiatives, has effectively addressed numerous issues. Let's now follow the author's exploration into American healthcare. How expensive is health in the U.S., truly? What lies at the core of this exorbitance? Are there viable solutions to tackle it? Part 1. Why is the cost of health so exorbitant in the United States? Let's delve into just how outrageously expensive health can be in the United States. Firstly, there's the literal price tag. The book presents numerous instances. For example, a skier experiencing altitude sickness, thought to be high-altitude illness by friends, was advised to inhale some oxygen. Uneasy, the skier decided to visit a hospital. After a quick examination, diagnosed with high-altitude sickness, they were asked to inhale oxygen at the hospital, a service billed at $11,000. Similarly, a woman spent 2 hours in an emergency room, receiving only one intravenous injection in some routine checks, accumulating a bill of $69,000, labeled as necessary comfort in care work. Another patient underwent full anesthesia for the removal of a tiny benign growth on a finger, costing $10,000. The charges for a straightforward childbirth in Boston ranged from $8,000 to $40,000, irrespective of whether it was at the most affordable or the most luxurious hospital, with no discernible difference in medical treatment. Many might think, just go somewhere else if it's expensive, but unfortunately, before your visit, you're unaware of the potential cost of treatment. Imagine if you knew in advance how pricey oxygen inhalation or basic checks in an emergency room would be, you'd likely try to avoid them. Regrettably, hospitals don't provide you with this price list, you only recall the medical services and corresponding amounts when you receive the bill. Besides the exorbitant prices, in the U.S., the high cost of health also stems from additional expenses outside medical bills. Some argue that high costs are justified due to the high value of doctors' services and the expensive nature of their education. However, many find that the priciest item on their bill isn't necessarily medical, it's unforeseen insurance expenses. One crucial cost is helicopter fees. For Chinese individuals, helicopter rescues in healthcare aren't common. Yet, in the U.S., wherever there are bustling hospitals, for-profit air ambulance companies flock, charging exorbitant fees. A short flight can cost hundreds of thousands of dollars. From 2007 to 2016 alone, average charges for air ambulance services from a company surged from $13,000 to $50,000, while the actual cost might only be 10% of what you're billed. While some might see helicopter inclusion in medical activities as a sign of a developed healthcare industry, providing faster transport for more effective treatment opportunities, in the U.S., over 80% of the 500,000+ air ambulance flights annually aren't emergency missions but rather resemble routine passenger services. Moreover, there's a lack of effective decision-making mechanisms in the U.S. healthcare system regarding whether to opt for helicopter rescue, ground ambulances, or patient self-transport. Helicopters and ground ambulances should be tasked with life-saving missions, yet U.S. government research found that 3 major corporations control 75% of the helicopter industry, aiming for frequent flights to maximize profits. When emergency assistance becomes an unbridled business, the high cost of health becomes a manipulated outcome. This brings to mind a familiar English phrase, "I'm fine, thank you." Remember, in the U.S., when someone asks if you need an ambulance or helicopter after an injury, saying this might protect you from excessive expenses. If the aforementioned high prices and hidden costs don't illustrate how exorbitant the cost of health is, the hospital lawsuits about to be introduced can render an American bankrupt due to their health. As earlier discussed, American medical bills can be outrageously high, prompting some to refuse payment or negotiate with hospitals, a reasonably common practice in the U.S. However, bargaining with a U.S. hospital is unlike haggling at a market. Our accustomed negotiation involves, "I won't pay a penny more, forget it," and the hospital might try to persuade you with, "Add a couple more dollars, I'll be selling at a loss," but the reality is, while you think you're negotiating, the hospital might not want to bargain or negotiate with you and might just sue you. Some patients might think, "I don't agree with this bill, I won't pay, let them sue." However, in the U.S., hospitals that win lawsuits can directly garnish wages from patients or even seize dividends from American citizens' retirements. If a patient lacks funds or assets that the hospital can claim, their credit score gets penalized, making it exceptionally challenging for them to buy their son a Christmas gift. However, from the perspective of these U.S. hospitals, offering services and patients paying is only fair and square. But the issue lies in the fact that these hospitals might have more reasonable approaches, like considering patients' actual payment capabilities, giving them the opportunity to manage within their means, rather than directly pushing them into bankruptcy. Ultimately, if patients knew roughly how much they would have to pay before treatment, it might change their medical decisions. Unfortunately, they don't have that option. Part 2. What are the core reasons for the exorbitant cost of healthcare in the United States? Let's delve deeply into this topic, which constitutes the crux of this book and is extensively discussed, the fundamental reasons behind the exorbitant costs of healthcare in the U.S., namely, opacity in pricing and information. The author illustrates the current state of medical charges in the U.S. with a vivid analogy. A buyer asks, "How much for this orange?" and the seller responds, "You'll find out after you've eaten it." From the perspective of American hospitals, they believe that prices are uncertain, even unreferenceable. This aligns with what we've previously interpreted in another audiobook, Social Changes in American Medicine. The U.S. medical system is a power field, where medical culture essentially embodies authority. Due to patients' faith in medical authority, they willingly accept the rules set by it. The opaqueness of medical pricing in the U.S. is prominently seen in price fluctuations that surpass market value assessments. Simply put, patients can't compare prices beforehand. The author narrates a real incident where a person opted for heart surgery, priced at $150,000 by the hospital. Feeling it was expensive, the individual did some research and found the same surgery in France for only $15,000. They decided to go to France for the procedure but were intercepted in the corridor just after leaving the room by a hospital representative. Urgently wanting to seal the deal, the hospital rep offered the ultimate price, "All right, $25,000. The patient was dumbfounded by the hospital's professional ethics. Despite being in a predicament, the hospital still sought to profit from them. Moreover, whether a patient has commercial insurance also dictates the price tag they receive. The author observes that in the U.S. medical field, there's often a tactic of initially raising prices, instilling fear, then highlighting insurance covering a significant portion, making patients feel like they're getting a good deal. The hospitals and insurance companies in the U.S. form a coalition, for insured patients who don't need to foot the entire bill, the final demand from hospitals isn't too high. However, patients without insurance are categorized as out-of-network, and hospitals impose sky-high charges on them. What's terrifying is that no one can ascertain the actual costs incurred by hospitals. What the author detests in American healthcare is not about the value of life or the actual cost of procedures, it's the businessmen gauging how much buyers can afford and setting prices accordingly. Given the multitude of medical litigations, the author visited U.S. courts, expecting a cold reception but was surprised by the warm welcome, as the courts themselves suffered from medical lawsuits. In the region visited by the author, 95% of the lawsuits stemmed from a local hospital. In this town, every 5 individuals, one had been sued by the local hospital and had their wages garnished. It vividly portrays the extent of medical litigation in the U.S. The author found thousands of cases where hospitals sued patients, and the hospitals almost never lost. The author attempted to investigate further, inspecting a copy of a medical bill, only to discover that all itemized details were redacted. The pricing and actual charges were all altered. With judges unable to see itemized entries, there was no way to judge if these prices were reasonable. This implies that if the hospital states it's reasonable, then it's deemed as such, showcasing the immense cultural authority wielded by U.S. doctors. The author increasingly believes that rebuilding trust starts with more honest, transparent, and fair charges for healthcare services. The author also experienced firsthand the disconnect between medical costs and prices. Surgeons often use an electric knife to cut harmful tissue during surgeries, creating smoke that might increase the incidence of lung cancer among surgeons and nurses. At that time, new electric knives and a new 4K display were available in the market. The new electric knife, with an added vacuum hole, could suction toxic smoke generated during cauterization. The new 4K display enhanced surgical visibility, thereby increasing safety. This was an opportunity for hospital equipment upgrades. However, the management, upon reviewing the proposal, questioned if the existing tools were still usable. This left the author speechless. From a managerial standpoint, as long as the existing medical tools function, avoiding additional medical costs seems justified. Yet, while it might seem to curb medical expenses, on the other end, they persuade patients to pay higher fees. The author discovered that U.S. hospitals profit from the difference on both ends. Additionally, excessive education also inflates medical costs. As a doctor himself, the author reflects on his medical education in current work, considering it filled with similar disconnects. Amidst rigorous studies, doctors are compelled to memorize knowledge that's easily searchable in the future, details like the distinctions between type 1 and type 2 multiple endocrine neoplasia, although most doctors might never encounter these rare, non-urgent diseases. Yet, for certification, all doctors must repeatedly memorize these obscure, non-emergent diseases and their specific genetic mutations. Apart from opaque pricing, there's significant information opacity in healthcare. The author recounts a story about a church. Initially, the author viewed the church's community activities, especially health clinics, as positive, believing they were benefiting residents. However, on closer inspection, these health clinics routinely screened numerous patients for peripheral artery diseases, guiding them to undergo surgeries at hospitals. The church's pastors were unaware, they merely sought more people to attend church events for evangelism and didn't inquire about what the doctors would do. In their understanding, doctors providing services to the community seemed like a good thing. Yet, they didn't realize that these health clinics had become a customer acquisition tool for hospitals. Through this method, hospitals excessively screened individuals and even performed unnecessary surgeries. The catchphrase for this health clinic's screening was simply, "Do your legs hurt?" Here's a better question: who hasn't had a leg ache? To borrow a phrase from Zhao Ben-Shan, you stomp your foot, you'll feel pain. So, while disease screenings appear to promote health, the screenings themselves can transform ordinary individuals into patients. The author believes there's an abundance of ineffective screenings flooding the market, often masquerading under benevolence, using highly improbable disease stories as bait to expand screening. In reality, most diseases are age-related, and the risk of multiple diseases for younger individuals is minimal. Patients recognizing the nexus between screenings and the medical industry are crucial to avoid becoming victims ensnared by commercial and medical interests. Part 3. How does the WISE initiative improve costly healthcare? In our discussion so far, we've explored the exorbitant cost of health in the current American landscape through data and cases. However, the most valuable aspect of this book lies in how the author seamlessly integrates ideas with action, which is incredibly inspiring. The author introduces a program called the WISE Initiative, aimed at improving the opacity of prices and reducing overmedication occurrences. As mentioned earlier, the author, being an insider and a reformer, stated, "As a surgeon myself, I'm familiar with the pervasive lure of money in the operating room." Thus, within the framework of opaque pricing and information asymmetry, the author's first focus was on the surgical field. Recognizing the potential for overmedication in many surgeries, the author highlighted a correlation with the way surgeries were staged and priced. For instance, in skin surgeries, the goal is to fully remove skin cancer while minimizing the removal of healthy skin. Surgeons perform the first stage by excising a piece of skin, counting as one stage. If cancer cells are found at the margins, they excise more, counting as stage 2, and in rare cases, stage 3. However, the fees for surgery aren't determined by adequacy or aesthetic closure of the wound but by these stages. This has led some surgeons to show disproportionately high stage numbers. Due to the authoritative culture within the medical profession, evaluating a doctor's tendency for overmedication purely based on staging isn't feasible. Hence, the author proposed the transparency of surgical staging to encourage compliance in surgical practices. The WISE initiative initiated a survey, calculating the average number of stages for each surgeon, revealing how frequently they operated. The data showed most skin surgeons averaged between 1 to 2 stages per surgery, while some surgeons averaged 3 to 4 stages. So, does this lead to reporting the outliers? However, the WISE initiative wasn't a reporting mechanism. For cases reported, doctors had space to explain. The idea was not to solely use data to determine overmedication. Only the surgeon themselves knew the reality. So, here's the twist. The initiative sent private letters to half of the surgeons, not for questioning or reporting, but to show them the distribution of staging among peers. These letters depicted the average staging and each surgeon's position in that distribution curve. Conversely, the other half didn't receive these letters and remained unaware of their positioning within the industry. The response was astonishing. 83% of doctors altered their practices, showing a significant decrease in later-stage surgeries in follow-up assessments. Additionally, even those not receiving letters desired similar data, wanting to understand their position within the industry. Some doctors expressed, "I love it. I've often wondered how my average staging compares to my peers, and here it is, dropped in my inbox. It's a great benchmark for our surgical quality." Regardless of receiving or not receiving these letters, all doctors showed a decrease in staging post-intervention, albeit the decrease was more significant among those who received the letters. If you're interested, check the graphs I've included in the text. This WISE initiative successfully proved that when information becomes transparent to doctors about their standing in the field, their behavior naturally changes. Hence, the goal wasn't to expose over boundaries, but to subtly alter those boundaries. Similar practices have been undertaken in our country. When a region showed over 20% benign lung nodule removal, a medical conference published the data. Post-publication, the region witnessed a significant drop in benign cases. Transparency and regulations lead doctors to self-consciously constrain their actions. Implicitly, a doctor cutting benign nodules, I can't judge if that's overmedication because benign possibilities exist and scientific limitations do, but a doctor consistently cutting more benign cases than others should introspect. Subsequently, the WISE initiative tackled the addiction issue with opioid drugs using a similar approach. In the U.S., opioid overprescription resulted in addiction problems post-surgery or trauma. Some patients received 60 or 100 pills, often due to the pharmacy benefit manager authorizing refills without the doctor's intention. In response, the author organized seminars to discuss common surgeries and their opioid prescription guidelines. Recommendations were democratically decided upon and landed between 10 to 15 pills, significantly lower than what patients often received. Using the same approach, doctors were shown their opioid prescription reports, detailing their position in the curve. The reports plotted different curves based on surgery types, eliminating any excuse for doctors citing unique patient cases. The book narrates a team member pointing to a dot on a graph representing a doctor's average pills per post-op patient, an astounding 45 pills. The author exclaimed, "That doctor is way off." Yet, in a touching turn, the author added, "No, that doctor needs help. Just like I did years ago." The WISE initiative not only reduced healthcare costs but also curbed patient addiction problems. Yet, the author discovered that a doctor's innate greed wasn't the primary cause of overprescription. Real change perhaps lies in altering rules within the healthcare system. For instance, doctors know that non-steroidal anti-inflammatory drugs, NSAIDs, are better than opioids for fever, pain, and inflammation, but they're hardly covered by insurance. Hence, doctors and patients are left with no choice but to accept opioids. The cycle perpetuates the healthcare cost driven by hospitals, insurance, and pharmaceutical companies. Apart from these instances, the WISE initiative made notable progress in various domains. For example, it unearthed that many gastroenterologists split endoscopies and colonoscopies, separately anesthetizing patients on different days, though they could be done in a single anesthesia session. Even though doctors could attribute it to patient cases, investigations revealed that most patients were treated similarly, possibly an inappropriate practice. Consider this: the data the author gathered could have been a double-edged sword, tempting to exploit. Some companies proposed monetizing these findings, but commendably, the author refused. The aim was to ensure doctor-confirmed evaluation criteria, obtaining doctor endorsements, being friendly to doctors. Medicine is an art, and doctors serve diverse populations. Guiding outliers to acknowledge their actions and adopt best practices was the goal. Therefore, I believe the author isn't a critic but a builder immersed in this industry, loving every patient and striving for constructive change. Alright, that's it for The Price We Pay. Let's summarize today's main points. The current healthcare prices in the United States have soared to a level that's almost unbearable for the average person. This exorbitant cost is often impossible to determine before medical decisions and easily leads to financial crises after treatment. The author believes that the main reasons for these high healthcare costs are opaque pricing and information. Therefore, the author advocates for clear and fair pricing. He initiated a semi-official program called the WISE Initiative. Through data surveys and private letters, he made the medical community aware of their positions among all doctors, prompting subconscious behavioral changes. This offers an excellent model for addressing similar issues. However, the author ultimately hopes for national attention and institutional adjustments and compromises. Issues like opaque pricing and overmedication exist objectively in any country. Despite criticisms of the American healthcare system, it's undeniable that the USA remains one of the most advanced nations in medical technology and drug development. In my book, Doctor, What Are You Thinking?, I delve into the reasons and mechanisms behind common overmedication. Ultimately, we all aspire for continual improvements in the foundational design of healthcare environments, preventing health costs from being excessively high, allowing patients better access to treatment, and guiding doctors toward benevolent practices. Congratulations, you've completed another book. Thank you all for your support and attention. Please subscribe to the Tim Booker channel, like, and share this valuable knowledge with your friends. Let's combine wisdom and action to achieve our financial goals and create a better future. Thank you, goodbye.